Uh, the question is, given the stark disparities in maternal mortality rates between Black women and their white counterparts, what specific systemic failures contribute most significantly to this crisis?
Well, for us, and for the issues that are disproportionately impacting African American women, I have to look at the root cause of many of the things. We have systemic racism in the United States that plagues every single system that is built upon, that this is built upon, including our healthcare system. And so when we look at our healthcare system, we look at our educational systems, when we look at all of those systems that look at those social determinants of health, and what goes on with African American women within those systems, all we can directly point back to is the impact of racism and how it impacts how much women are paid, where they are able to live, how they're able to live, the things that they are able to do, their availability of fresh fruits and vegetables in their community, around looking at food apartheid, and understanding all of the impact of all of these systems and how they disproportionately impact African American women, including our wage system that puts us on the bottom of everyone's wage, the wage gaps. And so when we look at African American women across the board, no matter what your educational attainment is, the likelihood of you dying or your baby dying is higher than white women who have never graduated from high school. And so we know that what we can take it back to is the commodification of African American women in slavery and looking at the racial systems that the United States is built upon.
So, not only do our social determinants of health affect the possibilities of Black mothers and their mortality or their child's mortality, but additionally, the systems in which those SDOHs exist, the systems in which the mothers live and subsequently die in, affect their health.
Yeah, every single system, whether you're talking about the educational system, the transportation systems, the housing systems, all of those systems, and then looking at cumulative impact, what's going on where they live around the air, the land, and the water. Like, what are they breathing? What are they eating? Where is it coming from? How poison is their neighborhood? Like, all of those things have a bearing on what happens to them, their bodies, and then ultimately their babies. And so for coming from this, the reason I, asked to be on the panel is because my aunt, who was born in 1927, 1930, had 17 miscarriages before she brought a baby home that lived in 1964. And my cousin made Jet Magazine in 1964. There was an article in Jet Magazine that talked about my aunt bringing a healthy child home after 17 miscarriages. When I was young, I couldn't understand what was going on with her. She came from West Virginia. So coming from West Virginia to Cleveland, Ohio, she was actually able to get better health care. But then we look at these systems and how they have evolved over that time. We have more women and more babies that are dying now than what was going on with her when she had my cousin in 1964. And that is problematic. Is you have a health system that has not progressed in the ability to make sure that African American women are able to live and that their babies can live, and that it has remained unchanged. If anything, our systems have gotten worse and it has not gotten better.
Miss Victoria, I would like to know what you have to say in your own capacity as a practitioner.
Yes, absolutely. I would agree with my colleague, and I thank her for bringing that up because that is an excellent point and a pertinent one that I think we have to be aware of, that systemic racism plays such a large role in our health outcomes. And we see that. I want to take a moment to, if we may please, just simply have a moment of silence to acknowledge all of the mothers that we've lost and the children that we've lost throughout this crisis that we're facing currently, not only in our nation, but we know that all across the world, this certainly is happening.
Thank you for that. I understand that that moment of silence could have been longer, but as we do have to move on, I'd
Yes,
like
yes.
I'd like to hear from Mr. Lee as well.
Yeah, I wanted to piggyback on a specific point that Ivanka and Victoria raised, and this is drawing from my own litigation experience. One of the things that we encounter here the most, kind of at the tail end of the healthcare delivery process, right, where systemic failures are sort of unaddressed, and ultimately if there's a culpable behavior, litigation ensues. It's one of the things we see is the lack of access to equivalent care, and it's both at the diagnostic level and therapeutic level. And racial and ethnic minorities, especially those who are uninsured or underinsured, and individuals who are lower on the socioeconomic spectrum, what we find is that they're often steered towards less expensive, lower quality, higher risk interventions. And I think a good example of that is a litigation that my firm led for the better part of a decade, concerned a controversial contraceptive device called Esure, where roughly 40,000 women, the majority of them people of color, women of color, sustained significant injuries, including internal perforation, internal bleeding, severe pain, even death. And during the entire process of R&D, clinical research, even post-market research, nothing was done. And it was really litigation the litigation that ensued that instigated the safety investigation, wherein the FDA ultimately instituted a number of unprecedented actions, including sticking a black box warning on a medical device, which, by our research, it was only the third time it's ever been done since the passage of the 76 Act. The device was ultimately banned by the FDA in 2018. And the FDA went so far in 2020 as to do kind of a post-market root cause type analysis, which they typically do that on the front end, but not a more sophisticated analysis on the back end. And so this is something that I personally have experienced with talking to a number of of Black women that our firm has represented, and so I just wanted to call attention and raise a specific point on some of the issues that were raised.
It is rather interesting to find that even in this modern day and age, when we think we are above most things, that people who are the most vulnerable are still being used as research by big companies and need to be represented by others, because not only do they not have access to how to know their rights, litigation also costs money and they may not have access to that. Dr. Smith, in your capacity as a doctor and as a researcher with population health, would you say that all of these is reflected in your work and you see these SDOH or systemic failures as well?
Thank you for the question. I would say yes, in agreement with what everybody has said. We are seeing that continuously in what women, particularly Black women, are experiencing in hospital systems, not particularly my system, but in hospital systems across the nation. The reality is that women aren't heard or listened to. Their pain is minimized when they enter into a system. They also are not triaged to be an emergent situation. So the triaging of them is limited, even when they are bleeding or when there is definitely a condition that could be preventable, because they're 80% of these of maternal mortality is preventable, right? And so that means that there is a minor issue that has not been addressed or has been exacerbated by ignoring a particular issue. But one of the things that this great panel did not mention in our system failures is the reality of having representation. Our systems are often failing Black and Brown individuals because they don't have representation within them. So some of the system failures are simply aligned with the policies and the procedures that are put in place to create barriers to everyone seeking a medical education and becoming an individual that would help within this system. And so we see that when there are providers, when there's representation, we see that our Black and Brown women are able to get the care that they need, or they feel safer within our health system. And so we haven't done that. Additionally, we have not done the work to heal the trauma or to even acknowledge the trauma that health systems have caused within these Black and Brown communities. And so we must acknowledge that trauma. We must begin to heal that. And so that's happening within our healthcare system failures within our insurance agencies is denial of particular procedures. You know, we hear, oftentimes we hear from physicians that there's a denial of a procedure because the insurance doesn't want to cover it. And it could be a preventive measure that would save someone's life. And so there are many system failures, not to even mention policies. You know, our politicians are putting policies in place every day that are around reproductive health, right? And in that effort of supporting those policies and creating those policies, that creates additional barriers to women seeking the care that they need. Our autonomy of the body is no different than exploiting the body with experimental procedures when you take away someone's autonomy to determine what they would do with their body. And so we see that overall. Additionally, systems still have policies and procedures in place that cause a large amount of stress within our communities. And so when we look at these disparities, not only do we see the racism within systems that is impacting our health, but there's weathering of the body. And so many Black and Brown individuals enter into systems every day, whether they're receiving services or whether they're working, that in some way exacerbate that stress or perpetuate that through the weathering of that body, those microaggressions, implicit bias, and just simply racism in those systems that exist. And so when we're in a nation where in 2024, we are still talking about the first Black CEO, the first Black person to serve as the first Black woman to serve as vice president, or the first Black person to be appointed to a board, that should acknowledge to us that that's not celebratory. The first Black person to be a Supreme Court justice, that's not celebratory. What that means is that there is still a system in place that perpetuates and exacerbates these racist behaviors that has gone on for years. And so now that person must stand alone in a system and try to fight those battles, which means their body is going to be weathering more, stressing more, because they are the only one at the table. And so I think for us also, we have to, within systems and outside of systems, change our behaviors. And we have to begin to change the direction in which we clap and applaud things that have just in some way perpetuated that same racist and discriminatory behavior in our systems.
Dr. Smith, that was a wonderful answer. Acknowledging the systemic failures that we've had, wherein we still see the first Black anything, or the first any woman, or the first minority to be in a position as something that should not still be celebrated in 2024. The stresses that people go through when they are in certain systems also adds to their failing health, and the trauma that we've discussed on healthcare delivery to Black mothers. Speaking of trauma, we'd like to discuss some historical trauma. How would historical injustice, such as the Tuskegee study or the exploitation of Henrietta Lacks, continue to influence the trust or lack thereof between Black communities and the healthcare system today? Ms. Hernandez, may we hear from you?
Yeah, of course. Hello, everyone. Thank you so much for having me. In terms of the extensive history, I want to talk about what you had discussed earlier, Divine, which was James Marion Sims, the father of gynecology. He experimented on various slaves, including Lucy, Betsy, and Anarcha, who I'll forever speak their names. Anarcha specifically was a teenage enslaved girl that Sims performed operations on over 13 times without anesthesia. And unfortunately, this kind of stuff still persists today because as early as 2006, allegations against Sims within the scientific community are still contested as to whether the patients were willing participants, regardless of the fact that Sims had to drug the enslaved women just to continue experimenting on them, the fact that they were slaves, bought and sold as property, and did not have the legal right to consent to such operations. They also don't take into account the historical context of controlling a Black woman's body during this period for the specific purpose of reproduction to continue within these practices. Further, as recently as 2016, 2017, and 2020, studies have shown that white medical students and trainees believe that Black people have thicker skin or are less sensitive to nerve endings than white people. These myths continue to influence the inadequate treatment of Black people, who are less likely to receive adequate pain treatment and medication. Black women are less likely to seek preventative services because of the lack of trust within the medical sphere and treatment regarding chronic health conditions due to a lack of trust in the medical profession, which has a rich history of stifling Black women's reproductive health, which can be seen within the Tuskegee study as well as the Henrietta Lacks. There's also a lack of Black healthcare providers and therefore a lack of representation within the Black medical fields, including Black OBGYN and nurse midwives, which result in inadequate, culturally competent care. In fact, in Georgia alone, only 19% of physicians are Black compared to 73% who are white. So we continue to see this history being utilized, right? And it's demonstrated between implicit bias that can't always be can't always be studied unless there are specific mandated compliance officers and a way to track such implicit bias. It is not surprising if you look at the history that Black women currently have high rates of chronic health conditions such as cardiovascular disease, diabetes, and hypertension, which often lead to conditions such as heart attacks, hemorrhages, excessive bleeding, preeclampsia, eclampsia. Often such chronic health conditions are left untreated or undiagnosed, and they lead to high-risk pregnancies for Black women and poor maternal health outcomes. And then as it relates to this implicit bias, we have trainees within the medical field and students who are matriculating within their profession and believing myths that date back to the 19th century that Black people have a higher pain tolerance and stronger nerve endings. So this continues to persist within history, and it continues to persist even today within our maternity care systems.
The emphasis put on the myths that medical students continue to believe today about Black people and their pain perception is really important, because not only does it affect when and how things like euthanasia or anesthesia are given to Black mothers, it also affects the kinds of treatments that they are suggested for or they are pushed towards by their medical professionals who don't truly understand them. Miss Victoria would like to say some more.
Yes, I think you make an excellent point, Gabby. Thank you so much. And here's a perfect example as to why representation is so important and how it influences trust within the medical system. When my family and I were researching our ancestral history, we found out that we had a great-great-grandmother, Henrietta Jeffries, who delivered more than 400 babies, both Black and white, in the rural South during the 1800s and 1900s. So because she was of the community that she lived in, she became so proficient and skilled in delivering babies that the white women stopped going to their white doctors because they saw the success that this Black midwife was having in delivering children. So, as anybody else would, they said, we want to go to the person who's delivering the babies accurately and who's ensuring that we live afterwards. As you can imagine, this caused quite a stir within the medical system back then. And there was a conspiracy that occurred. And she was brought up on charges of practicing medicine without a license. The penalty, if which found guilty, was death by hanging. So the 1910 United States Census lists her as a mulatto doctress. On a cold December day, she went into the courtroom and the judge asked Henrietta, on the charge of practicing medicine without a license, how do you plead? She simply said, Judge, if you mean that I helped those women when they needed me most, then yes, I'm guilty. Talk about weathering on your body. She had 13 children of her own and a husband, but she found something in maternal and child health that was so worthy of her profession, so worthy of her time, and so worthy of literally her life, that she was willing to put that on the line. The judge asked, how do you plead? And she said, yes, I'm guilty. And when he asked, who is your lawyer? She simply said, I have no lawyer. So the judge reviewed her track record in maternal and child health, rose from the bench, unzipped his robe, and came down and stood beside her and said, on the charge of practicing medicine without a license, I find you not guilty.
That is a really touching and intriguing story. And I think it does connect with things like the lack of representation, because she came in there without a lawyer. It connects with things with like the myths they're perpetrating, the constant pushing down of Black people and their successes in society. Ms. Hernandez spoke on implicit bias. I'd like to invite our panelists to try to define both cultural competence and implicit bias in the context of healthcare, and why would these be important for addressing the crisis of Black maternal mortality? Ms. Thompson, may we hear from you?
Yeah, so I'll start with implicit bias. So for like how I define implicit bias is that these are just thoughts that you are based on your environment, based on you grew up in. Like there's thoughts that you have that are either negative or positive for a group of people, right? And we don't realize that maybe that we have them, right? You're not overtly racist or sexist or any of those things, but just by your growing up, your environment, these are things you think. And cultural competency, I don't really agree with that word. I don't really feel like you could be competent in someone else's culture. But cultural humility is kind of what I identify mostly. And that is really when you realize that you have implicit biases or that you weren't exposed to certain cultural aspects of different cultures, because there's no way that you can know everything, but you're willing to learn and you're willing to say like, I don't know this, but I'm willing to look it up, research and know more, but also like I will find you someone that maybe has more training or education or willingness and like to go forward. So as far as like when it comes to the like Black maternal health crisis, so prior to going to med school, I was a doula and I served people from all different backgrounds. And I feel, especially with my Black clients, the biggest thing I had to do, besides just like having to serve with like the job description of a doula, but it was advocacy, because so many providers that they had were not didn't have cultural humility and didn't want to recognize their implicit biases at all. And instead of saying, maybe I don't know that much, or maybe I am like not the best person to serve you, they continued to serve and then put the blame back on the Black mom, right? Like now she's the angry Black person, right? Or because she's just speaking up for her help. So a lot of advocacy went into that. And then now that I'm in med school, like has been previous day before, I see so much implicit bias from my like, just from the physicians I see around me, and especially now that I'm in New Mexico, where less than 1% of the state population is Black, and maybe they don't have Black patients every day. It's really interesting to see that maybe they don't know, they're not culturally quote unquote competent, and trying to get them to admit that is very is a very interesting experience. So it's really important that providers of physicians, midwife, whoever, if you're serving Black bodies, Black families, that you are learning like daily about what is happening in society, what the historical trauma looks like. All those things are really important, and there's not enough training in the system to actually address the implicit biases.
You would be the, I believe, second person to have brought this up at BCPH, where we've heard of things like cultural humility, cultural sensitivity, just more ways to address the fact that understanding other cultures and approaching them in a humble, sensitive, appropriate way would greatly elevate the way that medicine is practiced. Dr. Smith, in your
Thank you. What a great explanation. I have some concerns about the entire bias conversation. I think we're living in a society that has determined a term to make one group feel better about their behavior, and that's what implicit bias does. Implicit bias states basically that you have a bias. It is okay. Here are some things that you can do to address that. Well, racism is not okay. And the things that you can do to address them, we should not have to determine for you. We did not build it, we did not establish, so we should not have to tear it down. We shouldn't have to do that. And so I think when we use implicit bias, I do think that people have biases. I think we all have biases, but it has just been put in place to soften and make more people comfortable with their racist behaviors. And we have got to call a thing a thing. If it is racism, we have to call it racism, because as long as we do not, we are going to have these same disparities that we are facing today. And that is the reality. Black women and Black infants are dying at higher rates today than they were before the end of slavery, which means our systems are still failing us. The systems that are being put in place to protect us, to serve us, are still failing us in many ways worse than they were when we were in bondage.
That is a very deep discussion and a very deep view of the entire situation. Wouldn't it be prudent to say that you get more with honey than with vinegar? And while, yes, racism is a thing that should not exist, it should not be allowed, it should not be cajoled, understanding that where other people are coming from and what may lead to those views would bring about more change than a constantly provocative approach. Doctor?
I couldn't get to mute fast enough. I would say if that is true, then we should see a decrease in maternal and infant mortality, especially among underrepresented groups, since we started the implicit bias conversations. We've been having them for a long time, and we have not seen a change. We have seen a change. We've seen, the disparities get worse, and we've seen the rates higher. So if honey was better than vinegar, then in this case, we should see a decrease in those disparities, and we should see a decrease in rates.
That is something to think about. I hope everyone watching this today would think about that. Miss Hall, I believe you have something to add.
Yes. So, Dr. Smith, look, the whole thing about racism is don't be. Like, yeah, that's what it is. Like, it is what it is. And so, the whole thing around implicit bias, one of the things that I look at is cultural proficiency. Like, what are you willing to understand about the culture that you're seeking to serve? And so we know that when we talk about historically around Henrietta Lacks, who had cervical cancer, not talking about the fact that she was a tobacco farmer and that tobacco farmers have a higher propensity to have cervical cancer. The fact is that services were not provided to her early on that should have been provided to her, but we are where we are. And then the Tuskegee experiment that they want to call a study, and it's not. You experimented on folks. You determined on your own whether you wanted to decide whether they wanted to receive medicine when it was available or not. That was your determination. You did an experiment. There was nothing studied about nothing. We never talk about the wives of the girlfriends and what happened to them, what happened to their babies, what happened during their pregnancies or whatever. We don't talk about those things. And, for us, it's because we want to close we are in the United States that wants to close the chapter on anything that makes it look bad. But you can't close the chapter on us because we here because you took us. Like we were forced here. Like we didn't voluntarily come anywhere. And so the other thing is since 1980, so we only have 2 times that African American health status has changed in the United States. It was right after emancipation with the establishment of the Freedmen's Bureau, which brought us hospitals and universities. Howard University was one of them. So a lot of the HBCUs came out of that legislation. So that brought us our own medical professionals that could help us. And so those very things saved the African American community from extinction. The second time was with the Civil Rights Act. So the Civil Rights Act integrated the hospital systems, but one of the things that it brought with it that we never talk about is community health centers. So community health centers is where a lot of people go to receive prenatal care that live in the neighborhood. Well, what we have seen is over these last 20 years, community health centers have quite changed. They have not only moved away from the communities that they were built to be able to look at, because remember, community health centers were something that was stolen from the Black Panther Party, because the Black Panther Party built these health centers, made these health centers so that communities could have a place to receive health care, right? And so we looked at that idea and said, hey, that would be a great idea. So the community health centers came from that language. And so what we have seen is like the staff of community health centers have become whiter and whiter, not looking like the communities. And then the other thing is the movement of those community services away from the urban core, more into more suburban areas. And so we have basically taken out vital lifelines that are important for the communities. The last part of it is since 1980, African American health status has just dramatically dropped. We look at, our health status as a whole. And so when we're talking about how do we get equity for African American women is go back to basics. Like, if legislation was used to help save us with the Freedmen's Bureau, then, what other legislative pieces can we put into place? Because we do have a lot of doctors who are working in neighborhood clinics because they can quickly get their loans forgiven that do not need to be here because they are indeed racist. I worked at a hospital in a neighborhood health center for 10 years. And so I got a chance to see firsthand about some of the biases that were going on, the racism that was just right in our face, where I had to go report to administration about the things that were going on the floor. And so I think that that's important for us to make sure that we understand that unless we speak up about the atrocities that are going on in our community, they will continue to happen. And that's why our voices are so important to this conversation. Thanks.
There was just so much that we all need to learn from that. Drawing from that, we actually would like everyone to know about the Flexner report, which, as you spoke about, we got HBCUs from Freeman's Rule, and that's when we began to have our own medical professionals able to service the community. But then the Flexner report was revealed, and it cut down a lot of medical universities. Dr. Smith actually brought that to the attention in the chat, and we would like to prompt the audience to look into that on their own. In the interest of time, we will be moving on, even though I'm very sure that all of our panelists continue to have wonderful things to add to every question. Our next question is acknowledging that all of our panelists represent various regions of the country. So from everyone's perspective, what policy changes would be necessary at the federal, state, and local levels to combat the high rates of Black maternal mortality effectively? I'd like to start with Mr. Lee, as you represented people and could note what things should not have been done or could have worked, or what you fought against.
Yeah, thanks, Divine. This is a question that's especially, I think, pertinent to what I do and how I feel about this issue. So my firm, we use the legal system at every level, at the federal, state, and local level, to raise awareness of patient safety issues and threats to public health. As I alluded to before, the litigations in which we're involved, they often implicate systemic inequities that were not resolved or even addressed in some cases in any earlier phase of the clinical process, including R&D, clinical or physician practice during post-market or observational research. So in my opinion, the legal system serves as a last resort, as a stopgap to inform policy changes, and also on a more personal level to secure individual justice for folks who've been wronged or ignored at every step of healthcare delivery. I mentioned the eShore litigation earlier today. I forgot to say that in that litigation, our firm, with a handful of other firms in leadership, we fought on behalf of these 40,000 women for the better part of a decade. And we were able to institute policy changes, prompting an FDA ban of the device, FDA sanction activity, in terms of punitive or deterrent, policies for both the corporate defendant and other corporations moving forward. But I think equally important is that it's while our firm works at a national policy level, we also work at an individual level, right? So these are folks who don't have access really to the legal system, and they wouldn't otherwise have access but for the fact that we're litigating in mass, right? We're representing tens of thousands, hundreds of thousands of patients who sustained similar injuries due to a common exposure. And this is a procedural mechanism the courts in the United States have created for a number of reasons, for reasons of judicial efficiency, judicial comity, so courts aren't reaching disparate decisions in different jurisdictions. But it's that we're working with very large numbers in order to effectuate these lawsuits, and ultimately we were in that litigation, we were able to secure a $1.6 billion settlement for these women, and that goes to taking care of their families, taking care of their past, current, and future medical expenses associated with this problematic device that was ultimately banned. And so we're operating at a national level, but we're also operating at a local individual level.
So more representation for people who have been harmed by the healthcare system is a way that continues to assist and should always be supported by the federal government. Ms. Hernandez, may we have your take?
Yeah, I feel like I have a bit of a different take, being a lawyer with a nonprofit organization called Sister Love. I am in-house with them, and what I do is advocate for certain policies at the Georgia General Assembly. We are a coalition of Black-led community-based organizations that also do community-based research centering the lives of Black women, such as Black Mamas Matter Alliance, such as Sister Song, Black Women's Health Imperative here in Georgia. And one thing I can talk about based on the advocacy efforts that I do, utilizing a legal framework within my work, is that Georgia has one of the highest rates of maternal maternal mortality and morbidity. We're 7th right now in the country. Georgia's Black infants are also dying at higher rates than most states in the country. Our birthers suffer from maternity care deserts and healthcare deserts, where about 75.5% of counties have no hospital or birth center offering maternity care, and over 34.6% of counties are considered maternity care deserts. Currently, that amounts to about 2.2 million women in Georgia living in these maternity care deserts with no OBGYN, no hospital or birthing center offering maternity care. And so based on just the research that we have done within Sister Love and the research done throughout our coalitions of community-based organizations throughout Georgia, we realized that the need to introduce a Black maternal health momnibus that has happened on the federal level, right, but and continues to happen within states such as Delaware, Michigan, I believe just passed a 3-bill package. Illinois and California passed theirs, and North Carolina, who has similar politics to us, is attempting to pass theirs, but they've had no luck thus far. And so I believe, and a lot of the members of our organization also believes that Georgia needs to directly invest in the equitable and comprehensive perinatal workforce to combat the lack of maternity care access in rural areas of Georgia in these maternity care deserts. Legislation such as the Georgia Community Midwife Act, right, that seeks to expand access to midwife practices so that grand midwives who have learned their practice through apprenticeships and traditional methods are able to legally practice if they have these certain qualifications, such as 10 years of experience and 50 successful births on the record. This leads to a diverse perinatal workforce that has cultural humility. We need a comprehensive bill package that addresses and seeks to research how social determinants of health, such as transportation, play a role in maternal health outcomes among Black women. For example, I want to highlight a study done by BMMA, which demonstrated that one of the key driving factors in prenatal care lack of access was that birthers' inability to drive because of the distance or to take time away from work to make their prenatal appointments. And this is specifically imperative in states such as Georgia that has these grand maternity care deserts. We need to pass legislation as well that requires implicit bias training. I understand some of the discussions around implicit bias training, and I definitely love the deeper aspect of it. But one thing that we're dealing with here in Georgia, which has kind of a trifecta as it relates to more conservative views, right, is that there is no recognition. There's no recognition of Black maternal health. They want to look at it, legislators want to look at it as a maternal health issue and not a Black maternal health issue. And recently we had a win kind of within our Georgia legislature where we were able to pass House Resolution 1059, which is the recognition of the state of Black maternal health in Georgia and the the impact of trying to implement systems that achieve Black maternal health equity. And so that is kind of the back and forth that we've been getting, where legislators do not want to accept that racism still exists, that institutionalized racism still exists. And so implementing these systems of implicit bias is the most that we have been able to do thus far, though I do recognize that that is not enough. And within these implicit bias trainings in all maternal health care settings, as well as compliance officers. So it's not just about introducing this training within maternity care settings, within medical schools. It's not just about that. It's also about compliance officers, about having a mechanism for women and birthers, Black women specifically, who experience this discrimination to be able to make a complaint, and therefore then the hospital would be held accountable. And these are legislative protections that should be mandated. I want to talk about like the trigger ban and how abortion, lack of contraception, attacks on medication abortion, how all of that encompasses Black maternal health. But I feel like I've been talking for a while, and we have a very diverse panel with a lot of different views. So I will be quiet.
It is it is interesting that you bring up maternity deserts, because on the 28th, the BCPH actually does have a webinar where we discuss maternity deserts and the ways in which they affect healthcare outcomes for mothers. Ms. Thompson, in your role or your situation as a student, how would you say, what policies would you try to float to better help future students so that they're not influenced by these myths and so that they have better abilities to help Black mothers.
Okay, so this also kind of ties into, I think, kind of the next question, but changing like some of the medical education needs to be reformed. One, there's not enough talk about the Black maternal health crisis in the curriculum, right? So having that be more prominent, it's hard for you to fix something or if you don't even know it's an issue, right? So a lot of times that is put on like groups or outside organization and it's not ingrained into the medical education that this is a problem and you as a physician or future physician are supposed to be part of the change. That's not talked about nearly enough or at all. Also policies to, before you even get to the medical education, you have to, a more diverse medical school, right? So if all the professors look a certain way, if the student body looks a certain way, it's hard for the one or two people that are passionate about this or to get their voice out there. So being able to have more African Americans, only less than 5% of the physician population is Black. And having less than 5% is not enough to serve the entire Black population of United States. So being able to change policies that make it easier for Black people to matriculate into medical school, having more DEI programs will all be part of the policies that are needed to kind of change the medical system right now as far as the education process.
Education is something that is continually important. We do need to diversify education. We need to think on ways to increase representation. And well, diversifying education would be a way to increase representation. And that would assist in the Black maternal mortality issue. It is important to note that the Midwife Act that Ms. Hernandez previously mentioned is another way to add access to care, add representation, add more advocates to the medical system. And maybe if we could all think of ways to integrate them with practitioners so that they can help voice their patients' needs to practitioners as well, that would be a wonderful way to assist. In the interest of time, even though I know that we are all bursting with passion about this topic and want to continue speaking, I will be moving on to the next question. We know that currently there are trends at Merck and other institutions to have diversity quotas for clinical trials on diabetes and other illnesses for minority populations. So how else can we fill in the current gaps in research to drive improvements in Black maternal care? How else can we fill in research gaps without hurting or taking advantage of minorities? I'd like to start with Miss Victoria.
Sure. So one other way we can fill in research gaps specifically, I think, has been done at Howard University. So through my work at Howard, specifically, we look at decreasing maternal mortality as well as infant mortality. One particular thing that we are quite focused on is funding surrounding Black Maternal Health Week. So acknowledging that at the end of the day, there are funding streams and funding cycles that oftentimes are set up to go specifically to communities and institutions who have historically held certain types of power. What we know is where the problem is and where the pain is also where the power is. So we have instituted our first Black Maternal Health Week last year, which began on April 11th, and we are certainly looking forward to doing the same thing this year. This gives us an opportunity to ensure that the community's voice is not only heard, but that the community's voice is valued and that the community can speak for itself, that the community has an opportunity to be able to show forth the solutions that they have already developed and those that are working well and those that they are improving as well. I'd also like to submit for your consideration another point, which is that we need policy change at every level. So at the community level, at the state level, at the federal level, and even in the clinic. Throughout my work, and I think we know this, we've seen that since 2007, obstetricians have counseled patients planning to give birth after a previous C-section with the help from a simple calculator that's designed to determine the likelihood of having a successful vaginal birth after a cesarean. So what we know is that this tool takes into account the patient's age, weight, height, and their history of vaginal birth. It also asks 2 questions. Is the patient African American? And is the patient Hispanic? What we found is that those answers specifically predicted a drastically lower chance of success for patients of color. Thankfully, that formula has now been changed, thanks to the work of community members, researchers, advocates, and clinicians who said, why are we using race to determine who deserves a C-section and who needs a C-section and who does not? So with the change of that specific formula, which oftentimes was used in clinical settings, we know that having that change has actually shown a dramatic difference. So again, funding helps certainly a lot, but policy change at every level is not only important, but vital and crucial as we think about the best ways to decrease maternal and infant mortality.
That is wonderful work to know about, understanding the ways in which healthcare decisions are made and ensuring that they are made in an equitable manner and in a manner that benefits people and doesn't just discriminate based on race is wonderful. Additionally, congratulations on the Black Maternal Health Week. Adding to what Ms. Thompson says, dragging more attention towards the Black maternal health, and not just seeing it as a maternal health problem, like Ms. Hernandez says, but understanding it as Black maternal health would add it to medical care curriculums, would add it to medical school curriculums, would add it to institutional standards of operation, and make this a problem that we all see and we all are ready to face and speak about. Mr. Lee, may we hear from you?
Yeah, thanks, Divine. This question is really important to me. It's something that I've grappled with a lot, in my capacity, also as an epidemiologist. And while diversified inclusion and exclusion criteria are a good start, clinical trials they really capture a narrow sample, right, of the population with a short follow-up window. Maybe a few hundred people over a year or so. What I'd like to see more of, is it's more active, thoughtful post-market surveillance and expanded phase 4 studies. You mentioned Merck, but it applies to all pharmaceutical and medical device companies, and their pharmacovigilance and pharmacoepidemiological practices. One example I like to, kind of theoretical or hypothetical example I like to throw out there is that in a clinical trial, if there's a safety issue, you really won't be able to, if it's rare or latent, you really won't be able to pick it up in a clinical trial. You might have, if you're only taking a look at 300 people over 1 year, anything that has that's rarer than 1 in 300 or more latent than 1 year, that's not going to get picked up. And so that's really what the intent of that post-market phase 4 period is, right? When you have millions of users over many years with a large enough sample size to really meaningfully stratify by various covariates like race, ethnicity, different maternal and risk factors, racial risk factors, things that I think are important in, to inform the conversation that we're having today that haven't really been done. And I speak to that, like I said, kind of in addition to my role at my firm, I'm also an elected member of the American College of Epidemiology. And, in that capacity, I work with others in leadership to think about these tough questions in terms of how, how data should be analyzed, how data should be reported. And right now, I'm happy to report we're working on a number of policy initiatives, really from the top down to structure better ways to assess maternal child health data. And it was surprising to me that this data really didn't, these policies, even at a high level, didn't exist. How can we have informed, detailed policy when the high level policy is still abstract, right? And so that's what we're working on right now within the American College of Epi.
Thank you very much for that. I would like to add to that, when we think on studies that are performed in healthcare, or clinical studies, a lot of the time, even when they do have diverse participants, they have a hard time retaining those participants, because we also have to look at the transportation. If it's an in-person study, keeping in contact with someone who most probably has to work insane hours or is working several jobs to keep up and does not have enough of an incentive to be present. I would say that one other way to increase the diversity of these studies, especially in a country where minorities are not easily reached because of the biases we've spoken about, would be to move these studies into communities that are more diverse, to fund studies that are coming more from minorities or minority institutions. Ms. Hall, we'd like to hear from you too.
So my take on clinical studies. So my organization does a lot of research. We partner with a number of universities, and we are actually the people who lead many of the studies within our communities. So, but people trust us. So that's one. So people don't trust a lot of the some of these other universities and health systems. And so that is, you have to build trust with the community in order for you to even think that the community is going to participate in a research study. Like, no trust, no study. That, I mean, it goes a little something like that. The other part of it is that African Americans are still dealing with the vestiges of slavery. And so because of that, the whole issue around clinical trials, there are other things that have to be tackled first. Merck and some of the other institutions can throw their weight into making sure that adequate policy is put in place. They have more money than all of us. And so they could actually say, you know what, we need some of these cities and local governments in order for them to look at reparation packages that include healthcare for all, that include a fair wage, that include an opportunity for medical schools for African Americans and African American students that are looking at careers in the health field, not just as a doctor, but as a nurse, as nurse practitioners, as midwives. Like, we need to make sure that the next generation of healthcare leaders are being funded by these institutions that claim that they are in line with our values. So if you are so in line with our values, use your dollars to help the politicians to change policies in our community. And then the other part of it is, you cannot do a research study on folks without remuneration. You have to pay people for their time. Like, you're not paying them to participate in a study, you're paying them for their time. If I'm leaving my house to go somewhere that's not in my neighborhood, or even if it is in my neighborhood, and I have to spend time away from my place, you need to pay me. So there's nothing that the Northeast Ohio Black Health Coalition does without making sure that people are compensated. We compensate people for their time. The days of giving people pizza and turkey sandwiches are over. We need to make sure that we compensate people for the time that they spent in order for them to get us the information that we need in order for us to get dollars. Because that's what the end of it is. The end of it is institutions are able to go after dollars, federal dollars, because of these studies. So if you are going after federal dollars and not looking at how you can make sure that the community is also compensated, you're going at it the wrong way. And so for me, it's important to make sure that the community is at the heart of all of this, particularly African-American women, who bear the larger brunt of a lot of the things historically that have gone wrong and gone on in our communities. And so because of that, we cannot talk about quotas. We cannot talk about clinical trials without talking about trust. But I think for all of us, we need to make sure that we are understanding the value of saying her name. All of these women who have lost their lives to these systems that have been unkind to them. You know, I have two young ladies that I promised their parents that I would bring up. One of them is Maria Welsh, who was 25 years old when she died in 2007 of acute respiratory distress disorder. She gave birth to a healthy baby girl who is now 16 years old and in the 10th grade. The other is Charmaine Wright. Charmaine was 26 years old. She died from complications from diabetes. Her baby also died with her. And so it's not that we have nameless folks. We got some names to go along with these rates that we're talking about. And so it's important for us to make sure that those names are always remembered and heard, and that we say, we're here so that we won't be talking about the next Charmaine or the next Maria. For me, that's why I get up to do this work every single day, because I could do something else. I do this work because in 1974, my mother was murdered in front of myself and my younger brothers. I promised that I would use my life to help change the lives of others. And so for all of us, we're here for a reason. And so we have to make sure that we use our power to push policy changes that can change our community, because we only get a short window of time to be here. So during that time that we're here, we have to use our voice to change our communities.
Understanding the need to use our voice to change our communities, and understanding wanting to use what our power and our knowledge and what we've achieved in life to affect change, I'm sure is why we are all here today. So we thank you. I noticed that Dr. Smith asks a question in the chat. We will get to you, Miss Victoria, but may I have you reiterate the question, Doctor?
Well, it wasn't simply a question. It was just the fact that if we are going to recruit more Black and African-American individuals to be in clinical trials, then the first step is to go to those communities and allow them to help us design, develop, and implement the clinical trial. And therefore, they are in that position early. They have bought into it. We have built trust, right? It is a intervention that it takes into consideration their culture, their practices, and their lives and their community. And if we want to recruit them, we must start with them, not get funding and then go to the community and ask them to participate in our research studies.
That does tie into what Ms. Hall says about needing to build trust and needing to connect with the community and their problems before we begin to ask them to help get us those government dollars. Just to put it out there for the audience and for our panelists to ponder in their consecutive and everyday lives is, does that then increase the funding required from the government? Because the time it takes to speak to the people, to keep them there, to have their opinions or to bring them out of their houses are also things that need to be compensated on the ends of the community and the researchers as well. And so we would have to see, or we would have to think about funding and how funding would be affected or would affect the ability to build trust in those movements. Ms. Victoria, may we hear from you?
Yes. I commend everything that's been said. And I think what's so important is that we're able to actually call things what they are. So what we just described has already been named in the terms of community-based participatory action research. So that specifically encourages researchers and community members to work together, as we have just said, through a method of trust and collaboration, and then a non-hierarchical partnership to try to improve the health of the community. This particular type of research, as we know, is so important because it can generate not just experiences from our community members, but it mandates that we involve our community members at the beginning, in the middle, and at the end. Of particular note that I think we should write down and not just keep in mind, but that we should bear in our hearts as we continue this particular journey, is that when it comes to community-based participatory action research, it allows us to dig deeper. So we've had a chance during our conversation today to talk about funding. Let's talk about data. Who does the data belong to when we're doing this research? What partnerships, what MOUs, what MOAs are we putting in place at the beginning that allow community members not just to actively participate, but to be the owners and the sovereign authors of their own destiny and their own fate, if we really believe indeed that Black women should have autonomy over their minds, their bodies, and their souls. So again, community-based participatory action research allows us to ponder these points even before we get started. So we're thinking about, as we mentioned, not just funding, but we're thinking about data, and then we're thinking about what happens once that research study ends. What does sustainability actually look like within that community? And what happens 10 years from now when the grant money dries up? In my training under our nation's 16th US Surgeon General, we were always taught to think critically. So as we think critically, we often recognize that so much of public health and maternal and child health in our nation really is grant funded. So I think we have to think differently and critically about ways to invest and ways specifically to build up the public health infrastructure within maternal and child health.
Those are wonderful things to think about. The community-based participatory action research is something that everyone should know more about, learn about, and is a wonderful way to add on to research studies and bring people in and keep their interest in research studies. Flowing from that, we'd like to consider the multifaceted nature of this crisis, and other than the type of research that was just pronounced by Ms. Victoria, what innovative solutions or approaches do our panelists believe hold the most promise for significantly reducing Black maternal mortality rates in America? Ms. Thompson, may we hear from you?
Sorry, I couldn't unmute fast enough. But yeah, I think there's not one, just not one thing. It's really a multifaceted issue like we've talked about previously. I think some of the things we could do is integrating community-based doulas and midwives into the care team, since they are the biggest advocates for our Black patients when they come into the hospital setting. Also developing culturally competent healthcare training program that actually face and actually talk about the bias and the making an anti-racist training for all health professionals, anyone that is going to be interacting or touching a Black body. Also, more funding to expand access to comprehensive prenatal healthcare, policy reform, community-based education. There's so many things. On the medical school level, starting early, having medical students advocating for policy changes, because that's something that we could do pretty early, interacting with other healthcare professionals and working as a team to make community outreach programs, and also helping healthcare professionals get cultural sensitive care and recognizing their biases.
So expanding on education with culturally competent training programs, allowing students to advocate for policy changes or instigating them to advocate for policy changes, and integrating midwives and doulas, as we've previously discussed, into the healthcare system to expand not only representation, but access to mothers, Black mothers alike. Ms. Hernandez, may we hear from you?
Yeah, I definitely want to echo everything that Alexis and Mrs. Thompson has said. I think that a great way to address this and reduce Black maternal mortality is to partner with community-based organizations that are conducting their own research in their community, utilizing models of inclusivity and reproductive justice standards that center the lives of Black women, right? A lot of these organizations are Black-led and center the lives of Black women, not only through their research, but a lot of them are midwifery practices. They have doula programs, and they provide care to the community and uplift the community while also uplifting the Black women that lead these community-based organizations. I think it's also important to continue to utilize the reproductive justice framework in healthcare systems and throughout healthcare policies. And it is necessary to achieve Black maternal health equity. Not only does it center the lives of Black women and marginalized communities, but it hinges on tenets of basic human rights that can be used to inform research models, public health policies, and healthcare systems. And if we think about reproductive justice in and of itself, right, it's a term coined by Black women for Black women. And when you utilize this model and this framework, you need to do the research on where it comes from and the history behind why reproductive justice itself and the framework within healthcare, within policies is so necessary. And in that respect, that is a form of education in and of itself. And raising awareness to the voices that matter most at this time in light of this crisis.
Communities are central. They seem to be central to every solution that we come up with. Even in the chat, Ms. Hall notes that cutting university fees and injecting those into communities other than harming students with inflated prices would be a way to assist communities, would be a way to add on to solutions for Black health. We do have a question in the chat from our
Just
audience.
to clarify, I mean university fees for grants. So if the university applies for a grant, 50% of that goes to the university. And so what they end up doing is if they get a grant that's 100%, then by the time they get their cut out, there's nothing left that's actually for the actionable for the community. And so I don't know how universities there work, but in Cleveland, that's how they work. And so what happens is, well, in Ohio, so if we get 100%, if there's 100% at the top, the university starts allocating it out to their own scientists that are within their university. So if they've started their own program, they are start getting a cut. So by the time you get to the end, they have no money left. So when they come to the community and say, we need your help because we have this grant that we need to fulfill, they have no money left. They come to us with nothing and say, oh, we don't have any money. So my thing is to stop doing that. So what they did with the EPA is the EPA, because I sit on the NEJAC, no longer allows them to do that. They can't do that anymore. They can't come in and take the majority of the money to say they're doing a project in the community and the community never benefits. So that should be stopped, which would allow more dollars to go into the community. And so that's what I mean. But their fees are astronomical too. But yeah, but I'm talking about their grant dollars.
Thank you for the clarification. That is just as important and something that we should all think about going forward. In the chat, a viewer asks, why are hospitals no longer keeping mothers after delivery? In Missouri, if you have a vaginal birth, they send you home the next day. Would Dr. Smith and Ms. Thompson answer this, please?
Well, first, I want to just acknowledge that universities actually take 51% of your NIH grants, but NIH adds that amount onto the amount that you requested. So they're not taking it from your research budget that we will have to budget communities into our research budget in order to do research in communities. And so we should do a better job as researchers to budget the community work into our budget. But they do take a large amount. If it's a PCORI, they take 40%, and that is not an additional amount. And so that should be considered when you're applying for grants, that maybe universities could change their policies and procedures to not take a larger percentage or to split that percentage with the community. All right, I will talk about keeping a mother there is evidence, and I'm just going to talk about the literature. The literature suggests that the mother is safer outside of the hospital than inside of the hospital, just because of different viruses and chronic conditions and other things that exist within a hospital. People are sick in there, right? And so when the mother is kept for a long period of time, the mother is more likely to be exposed to something that could cause an adverse outcome. So that's the first thing. The second thing is, it is not the hospital's choice. This is made by your HMO, your insurance agency, that have decided that after you have a baby, in 24 hours, you should be released home. So the blame in this, it oftentimes is misdirected in this. This is your insurance company decision, not your physician. Your physician doesn't really have a choice of whether or not to keep you longer if your insurance says that you must be discharged within 24 hours. So we should do more work around advocating and policy change in our communities or in our states around insurance agencies and how HMOs are making decisions to care for us, to decide what care we get. And oftentimes these are not physicians that are in HMOs that are making these decisions. So these are economic decisions. They're decisions made on the cost to an insurance agency and not the hospital or the clinician. So that I'm not giving clinicians a pass, but I'm just telling you that the HMO, your health insurance decides this, not your clinician. Just like your HMO decides that you don't only need to see your provider for about 15 minutes. Your provider has to see so many patients within a day for a particular reimbursement. And so if HMOs would change their pay structure, then your providers would have more autonomy in how they provide care to you. So you're only kept within 24 hours. I think the issue with that is that a lot of states have expanded Medicaid, or at least expanded postpartum care for up to a year after birth, right? And so you still have the right to receive health care up to a year. There are two problems with that. One, you're going to your family medicine doctor, you're going to your PCP, and there's less coordination between your OBGYN and your PCP, right? Two is that doesn't include advocates such as doulas or midwives or our community health workers that can see you when you get home. If we would just change our pay structure, that if you are once you are discharged from our health system, you still get some type of care and support throughout that 1 year of postpartum, whether it comes from a doula, it comes from a community health worker, or a dolu. They call them dadloos. I think it's dadloos. So there are men who become doulas, right? Dudeloos. There are men who become doulas and also are advocates for the family. And so that is the complication with that. The complication is not you being it is you being discharged within 24 hours, but the issue is not your physician. The issue is it's your insurance agency that has made that decision because they feel you're healthy enough to go home. The other issue is that there needs to be policies and procedures put in place by your state, who controls the health insurance agencies such as Medicaid, right? States have their own power over their own Medicaid, and then the insurance agencies to put in place structures that would reimburse doulas and community health care workers to follow you home and provide care for up to 1 year.
That, I believe, ties into everything we've discussed today, the amount of policies and advocacies that are constantly necessary for any change to take place, looking at how redefining pay structures from HMOs or from insurance companies, increasing pay availability so that alternative carers such as doulas or doodloos could also receive payment or reimbursement from said companies, and so that doctors would be able to have more freedom or more autonomy on how to care for a patient rather than going with a business decision. In the question and answer chat, Alfred Romeo makes note of the fact that they fully support PAR, which I believe is participatory action research, but some of those research studies about birth defects and other registries already exist, and these studies do not offer compensation. They know the need to do better in the future and do not want to miss the opportunity for Black women to participate and help learn more about medications and other exposures that might affect Black women differently. They are eager to improve research and daily messages to have healthier pregnancies and family. They say, thank you for this discussion. We thank you for joining us today. And we are additionally grateful to our panelists for all of their insights and their wonderful, wonderful contributions to these. One person asked if there's any way to find out about the research. They're in their last year of medical school and looking to apply to obstetrics and gynecology research next year, but would love to do any kind of research in this domain. I would like to point our audience into the various organizations that our panelists are part of, including the Northeast Ohio Black Health Coalition, Sister Love Incorporated, looking into the firm of Mr. Lee, and all of the other things that have been mentioned at our discussion today. Additionally, the Boston Congress of Public Health will have more knowledge and will have more, and Howard, and would have more information about all of this on our website. So if you would like to see more or know more about everything that's been discussed here today, visiting bcphacademy.org is a great way to keep up, to learn more about our panelists, and to know what other places can assist in this issue that we've discussed today. This very pertinent issue, especially considering our declining birth rates in this country. Thank you so very much, everyone, for joining us. We look forward to having you as more collaborators for our organization, and we hope you have a wonderful day. Thank you, and goodbye.
Thanks, Divine.
Thank you,
Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you,
Thanks.
everyone.
Thank you all. Fantastic panel.
You were amazing.
good one.
Thank you so much.
If anyone would like to connect, I'm gonna put my email in the chat, but that's not a forced connection, just, just if anyone would like to.
Thank you very much. Bye. Bye. Ms. Victoria, thank you for all that you said today. I noticed how eager you were and how passionate and all the things you had to say. I'm sorry we couldn't hear more from you because of the time, but we hope to see more from you in future webinars.
Yes, oh, the pleasure is mine. I'm excited about what you all are doing and just really hopeful that together as a nation we can move forward and that our children and children's children won't have to deal with the same disparities that we're facing. So definitely hopeful for the future.
I hope you have a podcast. You are an amazing storyteller. Just
That's amazing that you say that. That's literally what I'm working on as we speak.
Oh.
Yes, it's that'd be wonderful.
Yeah. Oh, thank you all so much. That literally is on the docket for this evening. So looking forward to it and hopefully sharing it with you all as well. I know there's one more webinar coming up in regard to maternity care desert. So definitely hopeful to be able to serve as possible on that one. And I'd love to share the podcast as well.
Thank you.
Thank you. My gosh.
Thanks so much, everyone. Take care. Bye-bye.
Bye-bye.
I think we still have some participants. Are you able to close out?
I'm trying to stop it.